Hey, ma'am, I called him again. There's no problem. He's joining in a minute, in a minute or two.
Okay, okay.
Okay.
You are the host, Dr. Vivek. You can make someone, anybody else, co-host it, like.
Okay, ma'am.
डॉक्टर विवेक
Yes, ma'am.
सर को थोड़ा लैपटॉप से ज्वाइन करने में दिक्कत
हाँ मैम, उनको मोबाइल से करने को बोला गया है अभी।
हाँ हाँ मोबाइल से हाँ डायरेक्टली ठीक है।
हाँ हाँ हेलो सर।
हाँ सुनाई दे रहा है।
यस
आवाज
सर,
आ रहा
वेलकम
है?
सर।
हाँ
यस
हाँ
यस, सो विल बिगिन द
मोबाइल
वेबिनार
से
नाउ।
कनेक्ट किया हूँ, देखता हूँ तो मटेरियल ले लेता हूँ मोबाइल में।
Shall I begin or wait some time? Shall I wait for some time or begin?
No, you can start by that time I'll share the content, start sharing the screen.
Okay sir, okay, thank you. Good afternoon everyone. Priyanka ma'am, shall I begin?
Yes, Dr. Vivek, please start.
Yeah, okay. Good afternoon everyone. I feel extremely glad to welcome everyone to this much awaited webinar by Nima Obgy Society Central. Myself, Dr. Vivek Zog, coordinating today's webinar with Dr. Rakesh Nayak. Before starting our session, I request all the dignitaries and all the participants to take a moment for blessing of Lord Dhanvantari. Yo Vishwam Vidadhati Pati Satatam Sanharayatyanjasa Srutva Divya Mahoshadhisha Vividhan Duri Karotyamayan Vibhranonjalina Chakasti Bhuvane Piyusha Purnam Ghatam Tam Dhanvantari Rupamisha Mamalam Vandamahe Shreyase. So may Lord Dhanvantari bless us with all good health and success. Let us continue and begin this webinar. On behalf of Nima Obgy Society Central, I welcome to all dignitaries and delegates for today's knowledge enhancing session on the topic of Ayurveda aspect of uterine myoma. First of all, I welcome Dr. Vinayak Temburnikar sir, President of Nima Obgy Nima Central, Dr. U.S. Pandey sir, Secretary of Nima Central, Dr. Ashutosh Kulkarni sir, Treasurer of Nima Central. Then I would like to welcome Dr. Kamini Dhiman madam, President of Nima Obgy Central, Dr. Priyanka Nakade madam, Secretary of Nima Obgy Central, Dr. Vishnu Bhavne sir, Treasurer of Nima Obgy Central, Dr. Rajesh Utane sir, Convener of Nima Obgy Central. I would also like to welcome Dr. Suhas Herlekar sir, President of Nima Obgy Maharashtra, Dr. Manoj Gayakwad sir, Secretary of Nima Obgy Maharashtra, and Dr. Ajay Bal sir, Treasurer of Nima Obgy Maharashtra. So before we go any further, let me give you a few instructions that are common to all participants. Please keep yourself muted during session. If your mic found unmuted or disturbing with the speaker's voice, you will be either kept in waiting room or removed from the session to maintain decorum of the program. If you have any questions, put your questions in chat box or raise your hand. Now I would like to brief everyone about Nima Obgy agenda. Nima Obgy is the National Integrated Medical Association Obstetrics and Gynecological Society of India, which aims to impart education in supporting and protecting the character, status, and interest of integrated medical professional in general practitioners and practitioners of Strirog and Prasuti Tantra, that is integrated obstetrics and gynecology in India. Our object is to spread knowledge and to foster education in integrated obstetrics and gynecology, including human reproduction, family welfare, study and research in the field of contraception and other allied problems. Nima Obgy is committed to promote services for betterment of health of the community, especially maternal and child health, prevention of ailments and diseases, their treatment with integrated approach of Indian medicine with modern science. So I'll take 2 minutes to give you all the important information regarding the upcoming event of Nima Obgy Society. As you all know, we all are Ayurveda fellows and we believe in Sambhasha Parishad. Nima Obgy Society Central is organizing an international conference, Sushruti 2023, Womb and Wound Saga in Nagpur in association with Datta Meghe Ayurveda College, Hospital and Research Center, Nagpur. This is a never before opportunity for all of us to meet renowned personalities in OBGY Ayurveda field and learn from them through hands-on training workshop, lectures, and live surgical demonstrations. This is purely knowledge sharing and enhancing type of get-together, which is even complemented by cultural events. For PGs, researchers, practitioners, and faculties, research paper presentations and poster presentation is also included in the program. So I request all of the participants and interested people to please register yourself as soon as possible and be a part of Ayurveda OBGY family. Thank you. So with this, let us continue to what we have come up today here. So dear all, as you know, today's topic is Ayurveda approach to uterine myoma. Uterine myoma, that is fibroid, is a commonly found entity in OB/GYN practice. We all know it interferes with menstrual bleeding tendency and causes disturbance in lifestyle of female patient. Surgical approach is assuring in the management, but chances of relapse are also there. So mostly hysterectomy is the last resort as per books. There are very less evidence-based medicine available for the medicinal management. So what today is our speaker, Dr. Ashokan, will guide us on this topic, but with the different perspective and share knowledge gained through his experience with us, and we all are keen to listen to him. So we welcome you, sir. We are honored here to have you with us. It is my pleasure to introduce you all to Dr. Ashokan, sir. Dr. Ashokan, sir, is head of the Department of Prasuti Tantra and Stirog at Alvaz Ayurveda Medical College, Moodbidri, Karnataka. He is practicing as an Ayurvedic gynecologist for 14 years. He has 70 publications in his name. He has worked with many PG and PhD students as a guide. And among his most known achievements is that he has received Vikram Sarabhai Award for submission of patent for drug on PCOD. He has contributed in instrument development in gynecology, and he was awarded as Prasuti Tantra Visheshagya Puraskar in 2021 itself. He is also interested in medical astrology. So without wasting any time, with due respect, I would like to call upon Dr. Ashokan, sir, to start today's session. Thank you, sir.
Yeah, thank you for inviting me, respected dignitaries of Nima Association and great practitioners from far and wide of India, and the appreciators and supporters of Ayurveda especially. And my background speaks something which I had put it in the last some session of Gita Parivar, as I am a volunteer of Gita Parivar for free learning and imparting the knowledge of Bhagavad Gita in a proper grammatical way. So let it be. I don't have time to change it right now. So once I share the screen, hope you will be able to make out the presentation. So without taking much time, I would like to go with the presentation. Shall I share the screen?
Yes, sir, please.
Yes. So as I was in a transit from Vadodara to Karnataka, Mudbidri, so it took some time for me to set my laptop and get in back to you. Sorry for the delay. And as we know, uterine myoma, my screen is visible, right?
Yes, sir. Yes, sir. You proceed.
Yes, sir.
Yeah. So the uterine fibroids are one of the commonest clinical condition which we come across, and it has been from when we were scholars in UG undergraduates, as well as when we were doing our PG studies, there was a great issue of this in 1990s and 20s, 2001 and 2010 area period. So last few 1 or 2 decades back, it was a major issue which there was no much what we can say is treatment available, or less treatment was known to be standard in Ayurveda field. Though the modern field of surgical intervention and non-surgical intervention both have some limitations, let us not peep into the limitations of surgical and medical interventions in contemporary practice. Let us see what we can do basing on the basic understanding of uterine myoma or Garbhashya Arbuda, as we say, the Ayurvedic correlation. So as such, to correlate any benign lesions, we need to understand it as the Mamsa Pradoshija Vikara. So if we understand the pathological growth factor as a Mamsa Pradoshija Vikara, we can, the Shastra Ksharani Bheshujam has been told. So surgical intervention is not contraindicated in Ayurveda for any type of Arbuda. Let it be Garbhashya Arbuda or any other type of Arbuda in Sharira. So as we know, Ayurveda speaks about Shastra Ksharagni Karma. What Shastra Karma, what Kshara Karma, and what Agni Karma could be the what delineates from each points. When to take up the Shastra Karma, when to take up the Kshara, and when to do the Aushadha Karma or Agni Karma. So is it Agni Karma indicated in case of the gynecological practice of Garbhashya Arbuda? How it is limited? So that we need to think about. And what the symptoms, the Hetu Viparita, Vyadhi Viparita, and Ubhayarthakari Chikitsa, we can adopt in Ayurveda. That also we need to think about. So to come with the introduction, if we say what is leiomyoma, or the benign neoplasm of the muscular wall of the uterus. So as we know, uterine wall is composed of 3 layers. One is the outermost serous layer, the middle one as the myometrium, and the endometrium. So uterine fibroids or benign lesions of the uterine cavity or that of the uterus may affect any of these 3 layers. So basing on which the symptomatology we will be able to we will be finding in clinical practice. For example, pressure symptoms including low backache will be more common in case of the subserosal fibroid, which are particularly more than 5 centimeter, or compressing the cavity and extending into the compression of the nerves and the pelvic cellular tissues. So the pressure symptoms and low backache and dragging pain and dislocation or translocation, or we cannot say translocation, dislocation or displacements of the pelvic organs. Displacement, not relocation, displacement of the pelvic organs. So this we can find in very well, which is evident by the low backache or the pelvic pathology. As well as the patient may have other symptoms like a myometrial fibroid of excessive bleeding, or menorrhagia, metrorrhagia, etc., with irregular menstruation. So Ayurveda says asragdara tadevati prasangena pravrittam anrutavati. Anrutukala, that is in between the menstrual phase, or intermenstrual bleeding, or continuous spotting for vagina. So these could be found more or less in case of the myometrial, and more or less in case of the what we can say is submucosal type of fibroids or pedunculated fibroids. So because of the mucosal origin or submucosal origin, we can say it is more or less pathologically, it is leading to excessive bleeding tendency. And it may be sessile fibroids, or it may be mobile, or pedunculated and non-pedunculated, or sessile. So that classification also we need to keep in mind while we are taking up the treatment modality. So this is the common thing which we come across in practice, different types of presentations. Then it is a benign problem of the muscular wall of the uterus composed primarily of smooth muscles. Incidence of leiomyomas is, though it is varying in different regions of India, if we do a survey study, we lack in survey studies. So whatever we say in percentage incidence or percentile incidence, it is all belonging to WHO status, or that it is related to the those who are unmute, kindly mute yourself. So those statistical data which we are presenting is of either of WHO or that done in some other countries, UK, US, etc. So in Indian data also, The government websites which we are getting, it is a composition of all the statewide data from the government hospitals. So we need to work on our area where there is uterine fibroid incidence, how much it is the incidence among the rural and the urban population. So how we can differentiate. Many of the studies which are carried out either are in urban population. So what about the rural population? What with that we need to think of. Then they are most common pelvic tumors of 20 to 40% reproductive age in reproductive age women in third to fourth decade of their life. Why third to fourth decade of life? It is the predominant period when they are in the sexually active period. So one thing, and there may be complaints of infertility associated with the excessive bleeding or menorrhagia, and fibroid uterus may be accidentally diagnosed when the patient is coming for the approach of treatment of infertility. So uterine factors as the positive factor of infertility, we come across the diagnosis of benign lesions. So this is the painful menstruation, that is dysmenorrhea is one of the predisposing condition where we suspect there could be the myometrial fibroids. So this is one of the space occupying lesions where we can find pain as a symptom. So vata is invariably involved. Contractility of the muscular tissue, mamsa dhatu tattva. Then, so keeping this thing in mind, the incidence, why we need to worry? Yes, we can do surgical intervention. In fertility, whom we have achieved the fertility, we can go for hysterectomies or abdominal or vaginal hysterectomies according to the size and position of the uterus and the need for conservative therapy or not. But so a study revealed in India annually 60,000 hysterectomies and 40,000 myomectomies are performed due to fibroid uterus. Then can we avoid or should we avoid it, or should we go ahead with it? Yes, it's needed, but how can we modify it? Where exactly is the surgical indication that we need to understand? So coming to the etiology, yes.
Sir, please, can you make the slides on full screen mode?
Yeah,
It
full
will be
screen
easy to
mode.
visualize.
I had tried
Yeah.
once, but it went for hanging, so I continued as such.
Okay,
Now
sir.
I'm putting it.
Okay, sir.
Yeah, now it is visible. So etiology is unknown. First and foremost, Daiva factor or unknown factor is being told. So keeping that thing in mind, the karma yat pauradaihikam or that adrishta hetutve sati hetutvam daiva shabdena. So these two references, we can say that there is some unknown pathology. Each individual myoma is unicellular in origin. Estrogens are not a causative factor of for growth of myomas, whereas myomas contain estrogen receptors in higher concentration around that surrounding myometrium when compared to the surrounding myometrium. It may increase in size with estrogen therapy in pregnancy, and it may not progress especially after menopause. So this makes the thing that if they are getting an estrogenic environment, there is a possibility of continuation of growth. So they are detectable, not detectable before puberty, and symptomatically also they are not detectable. Then progesterone increases the mitotic activity and reduces the apoptosis, thus increasing in the size. There may be a genetic predisposition. Suppose bija doshena daivataha yoni vyapat has been told. So the uterine fibroid or uterine myoma can be inherited. So if the parent had the female, had the mother had uterine fibroid, then that could be inherited to her a female child. So is a possibility. So that bija bhaga avayava and stri karanam bhavanam. So these three things which have been told in that garbhashaya bija bhaga dushti may lead to that particular manifestation. So this is not told, but anukta vyadi we are assessing. Coming to the pathology, frequently they are not single, they are multiple in number. It may reach up to 15 centimeter in size or larger. It may be firm in consistency. Gatra pradeshe kochideva dosha vrittam stiram mandarujam mahantam stirata. So firmness. And it may reach even up to 15 centimeter in size. Just imagine 15 centimeter in size. The uterus will be a resembling palpable abdominally, and it will be resembling a gravid uterus. on examination, abdominal examination as well as digital examination. So we can find out per vaginal examination, we can find out through the abdominal hack. Then spherical or irregularly lobulated. Here it may be uniformly spherical or it may be irregularly lobulated in appearance. So that we need to differentiate it from any myometrial fibroid from the adenomyotic lesions. So that we can differentiate basing on the capsule which is around the fibroid uterus, that is the uterine fibroid. Then have a false capsule can be easily enucleated from the surrounding myometrium. So for a surgeon, they can easily, so for a laparotomy, if it is done, then we can find out and we can even sub-centimeter fibroids, we can pluck out and remove by hand also or by forceps. So how many, if seedling fibroids are multiple in number, usually they are not single, sub-centimeter fibroid less than 1 centimeter or 0.5 centimeter, and they are multiple in number throughout, they distributed throughout the myometrium. So laparotomically also we can find out and if we can remove plucking one by one, but that is not feasible. There is no ultimate. So larger fibroid uterus, larger size, the myometrial fibroids are surgically resected. Then the pathological condition we have gone through. So, in addition to the this existing pathological mode, we have some other the understanding as Vata, Pitta, and Kapha. Also, we can classify and understand. So, basing on which the lakshanas which they produce may be pain as of Vata, maybe of Paithika lakshana like Daha, Paka, and Shleshma lakshanas like that of Mandaruja and Mahanta, Analpa Mulata, Stiravritita. So
Any issue, sir?
yeah, it is the PowerPoint is restarting. I'm sharing it.
Okay, sir. Okay.
So coming to the classification, so already as I have mentioned earlier, the classification of uterine fibroids is basically into submucosal, that is leiomyoma, pedunculated submucosal, sessile submucosal, intramural or interstitial, subserosal, subperitoneal, pedunculated abdominal, parasitic, intraligamentary, and cervical. So is my screen visible?
Sir, it is starting.
Okay.
Sir, it is visible now.
So please make it full screen, sir.
Yeah.
Sir, let it be. कोई issue नहीं है.
Okay, fine. Uh, Coming to the classification which I have mentioned, so we can very easily differentiate based on the symptomatology itself. We can differentiate. This could be possibly. And second thing is we need to go with ultrasonography so that we can find out the we can trace the exact pathology. Then the other the heavy symptomatological conditions are wherein we come across uterine fibroids are heavy and prolonged irregular acyclical bleeding, frequent in bleeding or frequency of periods, the menstrual periods, then pressure on the bladder and other pressure symptoms, chronic pelvic pain, low backache, pain during sexual intercourse, which is called as dyspareunia, infertility, repeated pregnancy loss because of irritability to the myometrium and irregular contractility. So these things will lead to repeated pregnancy losses, not more than the first trimester. So this could be the one of the clinical feature in case of the fibroid uterus. The secondary changes which are occurring in case of the fibroid uterus in the mass lesion is benign degeneration. They may degenerate in the deprived state of estrogen. Then they may go for benign degeneration like atrophic condition with hyalination, with yellow and soft gelatinous areas, cystic with a liquefaction and follows extreme hyalination, and calcific because of circulatory and deprivation, and precipitation of calcium carbonate and phosphates. When we treat in Ayurveda, I have come across the degenerative changes which are taking place. Usually they are that of calcification. Then septic and circulatory deprivation, that is by necrosis and infection. Then myxomatous or fatty, which is uncommon, as in hyaline and cystic degeneration, we can come across. Then red or carneous degeneration commonly occurs during pregnancy, edema and hypertrophy, which impede the blood supply, and they go for aseptic degeneration and infarction with the venous thrombosis and hemorrhage. So painful, but this condition with the venous thrombosis and hemorrhage, the patient will feel the pain, but it is self-limiting. So patient may feel pelvic pain on and off. Then patient may come to the doctor, get the ultrasonography done, or further investigation, MRI is done. Then the clinical picture comes from that it is uterine myoma. Then may result in preterm labor and rarely disseminated intravascular coagulopathy. Then the second pathological transformation is to malignant transformation, is very rare in with a 0.1 to 0.5% of incidence. The clinical features include only in 30 to 50% of the patients, symptomatically the patient may come with and these symptoms, as I mentioned in the introductory part, it is basing on the location where exactly on the 3 layers of the uterus this is located. Then it's a size less than 4 to 5 centimeter, sub-centimeter fibroid or less than 1 centimeter, and it's a position and changes and pregnancy. So its position and position, we can say it is more towards the avascular area. The process of growth is very slow. It is in the ligamentary area. The process of regeneration or growth is very slow. Whereas it is in the myometrium, the process of possibilities of growth is very high and rapid. Rapid in the sense it is a slow growing benign lesion, but it is a progressive growth is found. If treatment is not done, then during pregnancy, as it is an estrogenic state. Then the third, the one of the clinical feature, foremost clinical feature for which the patient approaches is this abnormal uterine bleeding. The most common is 30% with 30% incidence. Heavy or prolonged bleeding, that is amenorrhagia, leading to iron deficiency anemia. So if we take a peripheral smear, we can find out that microcytic hypochromic appearance of the peripheral picture of the blood, peripheral smear appearance. So that will lead us to the diagnosis of iron deficiency anemia. Then the submucous myoma produce the most pronounced symptoms of menorrhagia, pre and post menstrual spotting, bleeding due to interruption of the blood supply to the endometrium, distortion and congestion of the surrounding vessels or ulceration of the overlying endometrium. So these clinical features predisposes a person to suspect the manifestation of uterine fibroid. Then pedunculated submucosal fibroids with areas of venous thrombosis and necrosis on the surface, leading to the pictures of intermenstrual bleeding. Then pain. The second commonest complaint with which the patient approaches is with the dysmenorrhea. So dysmenorrhea or continuous pelvic pain, yoni vedana. So Tochitakala darshanam alpada yoni vedana cha artavakshaya lakshana yoni vedana or prayavarta yoni or pelvic organ pain in the pelvic region or pelvic pain. So pelvic pain, one of the causative factors is benign lesions of the uterine cavity. Then vascular occlusion with necrosis and infection, torsion of a pedunculated fibroid, that is acute pain. So acute pedunculated fibroid. So it is an emergency acute pain abdomen. Patient may approach you. If we give Hingvastakavati, Hingvastaka Churna, Lavanabhaskara Churna, Hingvachadi tablets, then Dhanvantaram tablets, Dashamulakwata, Varunadikwata, it may not work. So many a times it may require proper investigation for pedunculated fibroid and torsion condition, pelvic pain. So the condition will be similar to that of iliac pain, unilateral iliac pain, iliac fossa pain, as in ectopic gestation. Then red degeneration, according to the age of the patient and marital history and duration of marital life and parity of the patient, we need to approach differential diagnosis. Then red degeneration with acute pain, heaviness, fullness in the pelvic area, feeling a mass. If the tumor gets impacted in the pelvic organs, then pressure on nerves and back pain radiating to the lower extremities. Dyspareunia, if this patient goes to a general consultant, the patient will be given an analgesics or the treatment will go improperly because the lower limb pain, abhyangas, vedana, and the kati basti, so these things will not act here. So we need to differentiate. If it is a female patient nearing in the third or fourth decade of her life, there is a radiating pain in the lower limb, no anatomical x-ray doesn't shows any pathological change, the ultrasonography is not done, then the patient should be referred to a gynecologist and the evaluation should be, gynecological evaluation should be done. Dyspareunia is if it is of protruding into the pedunculated fibroid, cervical fibroid or low-lying fibroids. Dyspareunia is one of the clinical manifestation. Then that is deep dyspareunia, not superficial dyspareunia. Then pressure effects are it may be if it is quite large, the more than 5 centimeter, 4.5 to 5 centimeter, 8 centimeter, 10 centimeter, etc. Then if large, it may distort or obstruct the other organic functions, organ function like that of bladder, ureters, and it may put pressure on the ureters and reverse pressure leading to the hydronephrotic condition. The rectum, loaded rectum, then urinary symptoms, hydroureter, constipation, and pelvic venous congestion, So these conditions we may come across in case of the pressure effects. Rarely a posterior fundal tumor with extreme retroflexion of the uterus distorting the bladder base, leading to urinary retention. At the same time, the uterus is fixed retroversion. Uterus may go for fixed retroversion in case of posterior wall fibroid of sufficiently large size. So fixed retroversion, again the patient will complain of pelvic pain as well as low back pain. Then parasitic tumors may cause bowel obstruction. Then cervical tumors may produce serosanguinous vaginal discharge, which may be confused with that of malignancy. Then bleeding, dyspareunia, or infertility. So these are some of the pressure symptoms which we come across, or pressure effects of uterine fibroids. Then the most common complaint with which the patient in reproductive age come to us is late marriage, 30s to 35s to 40s, late marriage, delay in conception, first pregnancy, delay in first pregnancy due to a number of reasons, continuous use of OC pills. So such conditions we come across infertility. The relationship is with the infertility is uncertain. 27 to 40% of the women with multiple fibroids are infertile, along with other causes of uterine causes of infertility. Then endocavitary tumors significantly affect the fertility. Then spontaneous abortions include incidence before myomectomy, that are 40%, and after myomectomy it is reduced to 50%, but still 50% means 20%. So even after myomectomy, there is a possibility of recurrent abortions, or there is a possibility of regrowth of these myomas. So more in intracavitary tumors. Then how do we go with the pariksha karinohi kushala bhavanti, right? So examination. Most myoma are discovered on routine bimanual pelvic examination or abdominal examination. Retroflex, retroverted uterus, either of them or both of them, then obscure the palpation of the uterus. So we can come across the myomas which are obstructing the examiner's hand. Then anemia, laboratory findings include anemia, depletion of iron reserve, rarely erythrocytosis, pressure on the ureters, back pressure on the kidneys, leading to elevated erythropoietin. So this is very rare condition. I have not come across. This is just theoretically mentioned. So, but very rarely we come across, a chronic condition we may come across because of the pressure effects. So acute degeneration and infection. I have come across a patient with a uterine fibroid on the serosal layer and myometrial layer. And on examination, patient went for the vagal stimulation. So PV examination led to vagal stimulation. That was when I was not much experienced in practice of gynecology. In initial phase of my teaching career, I came across a patient. So that made me cautious in doing PV examination in case of patient with a known condition. This patient was not known. She just came with complaints of infertility. When the routine examination and PV bimanual examination was done, she was in vagal shock. So we could manage it somehow with the help of the experts. But still we didn't had any resources, as it was an Ayurvedic setup. We need to go with the Draksharishta, Muhur Muhupana, and Dhanvantari Vati and Hingvashtaka Churna to be kept in mouth in frequent sips. The patient could be reverted back to normalcy in some time. So the imaging include pelvic ultrasonography is of very helpful in confirming the diagnosis and excluding the pregnancy, and particularly in obese patient. So bimanual examination will be difficult in case of fatty 40 female. So that obese patient we come across difficulty in examination. Then saline hysterosonography can identify the submucosal myoma that may be missed on ultrasonography. Then hysterosalpingography will show intrauterine leiomyoma. MRI. So this HST, when done for tubal factor infertility, we can come across that there will be the additional findings of presence of uterine fibroids. We may be doing it for patency of the tubes. But we come across additional observation, as an additional observation, we come across mass lesion, benign mass lesions. It may be pedunculated mass lesions. Then MRI, the highly accurate in delineating the size, location, and number of myomas, but not always necessary. Then there are various other investigatory procedures. Differential diagnosis include usually easily diagnosed, exclude the pregnancy, exclude the other pelvic masses, then ovarian malignancy, that is purely it is delineating from the benign lesions of the uterine cavity. Tubo-ovarian abscess or tubo-ovarian masses need to be differentiated. Then endometriosis need to be endometriosis, and as well as endometriosis of the chocolate cysts of the ovary or endometrial cysts of the ovary, as well as the adenomyotic lesions. So Swiss cheese pattern appearance of the adenomyotic lesions and boggy appearance, then the hypertrophied appearance of the uterine cavity. So these things will differentiate it from, and non-linear growth, that is non-spherical growth. So that also will differentiate it from the uterine myoma. Then adnexa with the capsule, so glistening capsule appearance on the ultrasonography will help us differentially diagnose with the adenomyosis from that of the the uterine myoma. Then adnexa, omentum or bowel adherent to the uterus, exclude other causes of uterine enlargement like that of adenomyosis, myometrial hypertrophy, congenital anomalies, endometrial carcinoma. Then exclude other causes of abnormal bleeding and endometrial hyperplasia, endometrial or tubal carcinoma, uterine sarcoma, ovarian cancer, polyps. So polyps need to be differentiated from that of the cervical fibroids. Then adenomyosis, DUB, then endometriosis, exogenous estrogens. If there is any history of usage of exogenous estrogens, then endometrial biopsy or D&C is essential in case of evaluation of abnormal bleeding to exclude the endometrial malignancy. Then 2 out of 3 women with the fibroids or unexplained infertility undergo the myomectomy, and they achieve conception following which the myomectomy. Then red degeneration is one of the commonest condition. In second and third trimester, we can pregnancy, there will be a rapid increase because of the in the fibroid uterus or the vascular deprivation leading to degeneration. So either of thing may happen because of which position it is occupying. Basing on that, we can differentiate whether it will go for a rapid increase in size or is it degenerating. Then causes of pain and tenderness, various types of pain, as we know already mentioned, may initiate preterm labor if it is interfering with the placental implantation site or with the cervical fibroids. Then as well as the stretchability of the uterine wall, if it is affected, it may lead to preterm labor. Then manage conservatively with the bed rest, but the usage of narcotics is limited during pregnancy period, but tocolytics can be used if it is needed. Then after the acute phase, pregnancy will continue to term. Then during labor, the patient, if the fibroid uterus is of sufficiently bigger size, then uterine inertia may lead to, or non-coordinated uterine contractility. Then malpresentations, obstruction of the birth canal, cervical or ischemic myomas may lead to complications like which may necessitate the cesarean delivery. Complications in non-pregnant conditions, heavy bleeding with anemia is the most common. Urinary is most common. Then urinary, bowel or obstructive symptoms in bladder and bowel from large parasitic myomas. Then malignant transformation is rare. Urethral injury or ligation as complication of surgery to that of cervical myoma. there was the study, the textbook says that there is no evidence of OC pill increasing the size of myomas, but we positively find such examples in case of practice. Then post-menopausal women on HRT must be followed up with a pelvic examination who already had fibroid uterus. Then coming to the treatment modalities, depends on the age of the woman, parity, pregnancy status, desire to achieve pregnancy in future, general health condition like anemia, etc. Symptoms which the patient presents with: excessive bleeding, dyspareunia, fertility issues, pressure symptoms, etc. Size, sub-centimeters, or the smaller fibroid uterus, multiple or single. Then the anterior wall situated more towards the anterior wall or in the posterior wall. So this location also plays a role in Ayurvedic treatment modalities also. In my observation, is maybe my observation only, I have found that posterior wall fibroids respond better to the treatment Ayurvedic intervention than that of the anterior wall fibroid, myometrial fibroids. So not talking about serosal fibroid, myometrial fibroids. The blood circulation may be one of the reason, but as such the reason cause is an observation fact. The reason I don't know why there is a better response in case of posterior wall fibroid. Then emergency measures include blood transfusion to correct the anemia, etc. Platelet or then emergency surgery is indicated for infected myoma, acute torsion, intestinal obstruction. Then myomectomy is contraindicated during pregnancy. So in most of the cases, the symptoms will be asymptomatic with no treatment requirement. Post-menopausal, no treatment may be required, as there is a less possibility of further continuation of the growth of the fibroid uterus. Then the other causes of pelvic masses must be excluded, and surgery is contraindicated as such in pregnancy. So laparoscopically it can be done. The only indication of myomectomy in pregnancy is torsion of a pedunculated fibroid. Myomectomy is not recommended during cesarean section. Pregnant woman with the previous multiple myomectomy, or especially if the cavity was distorted or entered, should be delivered by cesarean delivery to reduce the risk of scar rupture in labor. So results of treatment: decrease in symptom size of the myomas is found to be 50% to the maximum extent. In 3 months of treatment, this differentiation could be observed. The patient should be convinced that it may take time. So dietary habits and modification are also a must during the treatment period. Then amenorrhea and hypoestrogenic side effects occur as a treatment modality intervention of by the suppression of GnRH secretion. Then and further HPO axis dysregulation. Then osteoporosis may occur if the treatment lasts more than 6 months. So these are limitations in the medical line of treatment in contemporary sciences. So how we can overcome it with the Ayurvedic integrated approach, that we need to understand. It is indicated for reducing the bleeding from myoma, except for the polypoid submucosal type. So pre-operative to decrease in size allow for vaginal hysterectomy or myomectomy, and laparoscopic myomectomy can also be the line of treatment. So the treatment with the GnRH agonist have got some benefits, at the same time they have got some limitations. Then supportive measures include the pap smear, endometrial sampling for all patients with excessive bleeding or irregular menstrual bleeding. Before surgery, correction of anemia is prerequisite. Prophylactic antibiotics should be administered. Mechanical and antibiotic bowel preparation if difficult, surgery is anticipated. Then The prophylactic heparin can be administered post-operatively. Then evaluation and differentiation of neoplasia, myomectomy for symptomatic patients whom wishes to preserve the fertility, conserve the fertility. Then various types of myomectomies can be practiced in as a surgical measures. Then uterine artery embolization is one of the measure which is used. And with this brief background, if we see the Mamsa Pradoshaja Vikara, which is commonly found in case of fibroid uterus, familial tendency or family history will be always positive, and the patient will have chronicity. Acute cases are less often seen in our practice. So patient may come with infertility of 5 years, 6 years, 10 years. Then we can come across in investigation reports. If not already done, there may be need to be done. If done, there may be a any of the history of surgical intervention for myoma, that is myomectomy, might have been done, or else the patient might have the carried with the medication. So those things we can come across in case of the Stiravradhita, and that is a chronic onset and continuation of the pathology. Then Mamsopachayam to Shofam, it has been correlated to the Shofa. That condition is said to be Arbuda. So Shofa, whenever we say Trishothi Adhyaya, we come across Trishothi Adhyaya, we come across the clinical pathological conditions of Shotha or Shvayathu or Shofa. So these are, there is some mild difference between the terminologies. So we need to understand any of the Shvayathu Chikitsa or Trishothi Adhyaya Chikitsa can also be safely employed in case of
कंट्रोल नाहीये सगळे आणि मामापेक्षा मामीला तशी सवय तिखट तेल चमचमीत
So doshas involved may be vata and kapha, doshas are rakta, mamsa and meda. So as such, mamsa will be reached, touched once the rasa dhatu dushti, rakta dhatu dushti, and uttarottara dhatu dushti leading to mamsa pradoshaja vikara. Then once the mamsa pradoshaja vikara is left untreated, like Sroto Vimana of Charaka Samhita, what he speaks on mamsa pradoshaja vikara nidana. So those things, if indulged by a person, that may lead to Pishitashanadi, that may lead to Mamsa Pradoshaja Vikara. Similarly, that of Medo Pradoshaja Vikara. So these causative factors which are mentioned also to be traced in patients with the uterine fibroids. Then other medication history also should be traced. Then Sangha and Siragranthi can be the major pathological changes. Mala Sangha as Sangha and Siragranthita as an Granthita. Then Srotas which are involved are, especially Rasa and Rakta are invariably involved before affecting the Mamsa Dhatu. Then Mamsavaha Srotodushti, Arthavaha Srotodushti are additionally found in case of the Samprapti. Then types as we know, it is Doshaja, Ekadoshaja, then Medoja, Raktaja and Mamsaja. So predominantly we come across Mamsa Dushti, so it is of Mamsaja Arbuda. Then so these are the lakshanas of dosha wise. So we seldom diagnose it basing on the dosha lakshana. Ayamyate vyathyata eti todam pratyasyate prastyate eti bhedam krishnor amrudur bastirivatascha bhinna sravecha anilajo asramacham. So this is about the excessive bleeding which is found in case of the uterine myoma. So that is more commonly seen in submucosal variety. Not correlating, I'm thinking in line with Ayurveda. This is the lakshana which is told, whereas the Vedana lakshana will be predominantly found in Vataja, whereas Vedana lakshana will be predominantly found in subserosal and myometrial fibroid. So subserosal fibroid, Vedana lakshana will be pelvic pain, whereas myometrial fibroid, Vedana lakshana will be Toda, Ruja, Pheda will be of dysmenorrhea and dyspareunia. Then Pittaja Arbuda lakshanas like submucosal, Dandatyate, Dupyati, Doshyate cha, Papachyate, Prajvalati vachapi, Raktasya pito athava pitta bhinna srave dushnam ativa chasram. So all the conditions they are mentioning bhinnaha srave dushnam. So if it is a sessile or if it is pedunculated, if it is cut from the root, then there will not be much bleeding. If it is not enucleated and with encysted capsule, if it is not removed, there may be srave dushnam ativa chasram lakshanas may be found. Then Daha lakshanas are predominantly found in case of the Pitta Jarbuda. So Lakshana Chikitsa is Upanaha, Ushna Taila and Shira, Upanaha with Veshvara, Trivra Sikdagrita, and Tailapana and Nadi Sveta. So these are mentioned. Then Kaya Virechana, Udumbara Shaka Vendak Shaudra Lepa, Rakta Visravana, Draksha Rasapana, Yashti Madhugritapana. So these are some of the Pitta Jarbuda Lakshana Chikitsa. Then Kapaja Arbuda Chikitsa, intramural fibroid, which is very slow growing. It will not be producing much of the pain symptom except for dysmenorrhea due to non-coordinated uterine contractility. Then tumor, cold, abnormal color, little pain, excessive itching. So itching we cannot find in case of an uterine myoma. So we need to delimit that lakshana. Dense, like a stone-like appearance, when burst discharges with white pus. So these lakshanas are seldom found in case of a Paka lakshanas will not be found. It will Bhinna Sravet lakshana is less frequently found, more or less frequently found in case of uterine fibroids or myomas. Then Kapaja Arbuda Chikitsa, this is the Arbuda Chikitsa, but it is not Garbhashaya Arbuda Chikitsa. So we need to accept the lakshana which are told there. We have to modify it to the Mamsa Pradoshija Vikara or Mamsaja Arbuda lakshana. In that, if it is Vataja lakshana predominant with Paitika lakshana predominant, Shleshma lakshana predominant, accordingly we can treat. Then Vamana, Kshara karma with the Paniya Kshara, Agni karma, which is more for surface lesions than that of the internal organic lesion. But on surgical table, we can do pottery. So that is Agni karma. Then Kalka Dharana, Gomutra Kshara Yukta, we can give Kalka Dharana also. Gomutra Yukta or Kshara Yukta. Then Medoja Arbuda, Sharira Vriddhi, Kshaya Vriddhi Hanir, Snigdo Mahan, Analpa Rujo, Ati Kanduhu, Meda Kruto, Gachati Chatra Bhinne, Pinyaka Sarpi Pratimamtu Medaha. So once we dissect the uterine fibroid, in case of myometrial fibroid, we don't come across any Pinyaka Sarpi Pratimam. But adenomyotic lesions, some of the condition it may resemble that of Pinyaka Sarpi Pratimamtu Medaha. But in myometrial fibroid, we never come across. It will be in concentric rings or proliferations of the tissues. We may find the dissected mass. So the Medoja Arbuda Chikitsa should be done here also. So Meda Vriddhi leads to Vriddhi of Sharira Vriddhi, Kshaya Vriddhi Hanihi. So just like that of the other lipomatous lesions on the skin, or what we can come across subdermal. So similarly, we can find the lipomatous lesions, Kshaya Vriddhi Hani, as the Sharira Vriddhi, Medo Vriddhi occurs, it will enhance, it will reduce once the Medo Vriddhi reduces. So that lakshanas are also told here. Then Raktaja Arbuda lakshanas are less frequently found. Dosha Pradushto Rudiram Sirastu Sampidya Sankocha Gatasthapakam Sasrava Munnakhyati Mamsa Vindam Mansankure Rachitam Ashuvriddhim Sravatyajasram Rudiram Pradushtam Asadhyameta Duratnapansya Rakshayod Upadrama Peditatva Pandur Bhave so Arbuda Peditastu. So Panduta as a lakshana and complication will be found. Upadrava Bhuti Uta Pandu lakshanas will be found and Raktakshaya lakshanas will be found. Amla Shishara Pretihi Sirashaitilata Rauksheta. Then Brahma lakshanas and Asrugdara Upadrava lakshanas will also be found in case of Raktaja lakshana. So where there is characterized by dysfunctional uterine bleeding, intermenstrual bleeding, Asrugdara lakshanas. So the treatment which is mentioned in class 6 is Vedana, Dharana or Patana, and Shodhana and C1. Then Lepana with Haridra, Grupadhuma, Lodha, Manashila are classically mentioned. Haratala with Madhu, and Karanjataila application is mentioned. So practically, less frequently we do these classical treatments. We have modified treatment modalities of usage of Vashayas, Asavarishtas, Dhrutapana, Shodhana, then Shodhanottara, Shamana. So either Vamana or Virechana is initially done. Usually the first line of treatment will be Vamana, and Nasya is not preferred initially. Then Rakta Mokshana is also less frequently done in practice. Like Rakta Mokshana in Garbhashya Arbuda is a field to be explored. How we can improve in Rakta Mokshana as a line of treatment, but preferably Rajasa Shuddhyate Nari has been mentioned. So once the irregularity of the menstruation is corrected, the Rakta Mokshana Chikitsa can be avoided. Then Mamsaja Arbuda Lakshanas like a Mushti Praharadibirartenge, Mamsam Pradushtam Prakuroti Shoham. So this Arbuda is more common in case of breast lesions than in case of uterine lesions. Avedanam Snigdha Mananya Varnam Apakam Ashmopamam Aprachalyam Pradushta Mamsasya Narasya Badam Etad Bhaveta Mamsa Parayanasya. So the last line Mamsa Parayanasya, the dietary habits are so commonly used formulations include Kwatha of Varunadi Kwatha, Chitraka Granthikadi Kwatha, Gugulu Tiktaka Kashaya, Panchatiktaka Kwatha, Varuna Shigru Kwatha, Palatrikadi Kwatha. The Snehapana can be done with the Panchatiktaka Gruta, Varunadi Gruta, Mahanarayana Taila. Even Panchagavya can be given in some case of a Mamsa Parayanasya. So those patients who are frequently using non-vegetarian diet, Panchagavya Gruta can also be employed. Then Tripala Gruta can also be used. Then Mamsa Medo Pradoshaja Vikara Ukta Chikitsa, whatever the Gruta Prayogas are mentioned, those can also be brought in here. Then the Gugulu Tiktaka Gruta can also be used. Then Shodhana with the Vamana, as if it is predominant with the Shleshma Pradoshaja Lakshanas like a Staulya Vikara, Mamsa Pradoshaja Lakshanas are found, then we can go with the especially Shleshma Pradoshaja Lakshanas, Tikka, Shvasa, Kasa, as well as with the Urva Amasha Vata doshas, then we can give with the Vamana. Then Rasa Pradoshaja Vikara, then Nirami Karanartham, Deepana Pachana should be done, followed Snehapana and Vamana can also be done. Wherein the Bliha Vikaras or associated Lakshanas are found, then Agni Mandyadi Vikaras, Grahani Dushti because of irregular dietary and Aushada, Basti, which include initially Lekana Basti can be applied, followed by Shara Basti. Lekana Basti is in the form of Basti, followed by the Brahmana Bastis also can be employed in case of lean patients or those patients who are seeking fertility, also be employed after the Lekana Basti and Kshara Basti. In addition to that, we can give intrauterine installation of uterobustis, which can be beneficial in case of the Ksharabustis, may be beneficial in reducing size and number of uterine fibroids. Then the oral medications include, which I used commonly, are Nityanand Rasa with proper Anupana, Kanchanar Guglu, and Tapya Diloha for correcting anemia also, and which is Lekana in also nature. Then Medohara Vedangaloha, Lohasava, Kumaryasava, Ashokarishka, Abhyarishka, Chavikasava. Then Pushyanga Churna in case of symptomatic management of menorrhagia, intermenstrual bleeding, Pradharanta Karasa, Aragyavardhini Vati at Yakrat Vikara Harana. Then Mulaka Kshara Paniya Kalpanas and Shivakshara Pachana Churna Manipadraguda. So these things can also be used for Nitya Virechana purpose. We can give Manipadraguda. And then very less slides are remaining. I'll complete it. Palashakshara, Apamakshara Jala, Haridra Khanda, Hema Kandakrita, Gomutra Haritaki, Nagakeshwara Churna, and Jalakumbi Churna. So these are some of the treatment modalities which are practically used and found beneficial. So Ayurvedic intervention in the management of uterine fibroids, a case series have been published by Department of Prasuti Tantra and Sriroga, Rajiv Gandhi Paprola, Government Postgraduate Ayurveda College Paprola. So under the guidance of Kamini Madam, I don't go into the detail of this study series. It has been the found beneficial with Kanchanara Gugulu, Haridra Khanda, in the management of uterine fibroids. So various studies have been Hema Kanda Gruta Siddha. Gruta is found beneficial as per a study conducted at IPGT and Jamnagar under the guidance of Lakshmi Pedaya Madam. Then successful management of uterine fibroids by Ayurvedic treatment. Some other than the gyneco, the Prasuti Tantra Vibhaga, this publication has come out. So there we can go through, we can note down the title of the studies so that you can put the search words, keywords, and you can find the, you can get the result of what is the content of the publication. Then pathophysiology of uterine fibroid and Ayurvedic perspective, a review has been done by the CCRS National Institute, National Ayurveda Research Institute of Panchakarma Chaturthi by Pradeep Kumar sir. So Dr. Pradeep Kumar has done this study. Then management of Garbhashaya Arbudha uterine fibroid, a case study has been done under the guidance of Ramesh sir and Padma Saritamba. Then clinical evaluation of Hemakanda Gruta on Garbhashaya Arbudha. So this has been found to be very effective. The scholar has put much pain to do this study, and the guide has guided the scholar at every step so that the observations are very precise. Then efficacy and safety of the two Ayurvedic drug regimens in uterine fibroids, a randomized single-blind clinical trial. This also proved to be, it is from Sri Lankan in the population. So the dietary habits, their the behavioral changes will be different, and the climatic conditions are also different. So, but the observation has given the very important clinical observations have come out of this study also. So, Ayurvedic approach in the management of uterine fibroids, a case report. Then we have one more publication called Integrated Effect of Yoga and Ayurveda on Uterine Fibroid, a case report. Though I have done multiple studies, I have not published any. A few complications also I observed in few conditions. Uterine fibroids in Ayurvedic perspective, but whereas our publications are not highlighting the negative impact of Ayurvedic drugs. Though we don't have much negative impacts, if we continue the Karshana Chikitsa for uterine fibroid for prolonged period, in my observation, I have come across Kapakshaya Lakshanas in many patients. So Kshina Kapha Lakshanas and Vata Vriddhi Lakshanas are observed in a few patients. So uterine fibroids in Ayurvedic perspective. Then we have one more publication called Fibroid Uterus, a single case study. It's from the Department of Shalya Tantra. Then understanding the fibroids in light of Ayurveda is one more publications. So there are various multiple publications. So clinical evaluation of Hemanta that I already have told. Then we will come across one. This study speaks about current progress of Ayurveda treatments on uterine fibroids, a comprehensive review. This publication speaks about almost all the studies done till that time by using Shikru, Gugulu, Kanchanara Gugulu, Haridra Khanda, Ashokarishta, and Lohasava. So, what symptomatic treatment is spoken with? But a comprehensive SOP in the management of uterine fibroid through Ayurveda is needed so that all gynecological practitioners of Ayurveda in India, as well as those who are practicing integrated medicine abroad, they can use the similar line of treatment in similar symptomatic observations. So this is one of the Palasha Ksharodaka is also Paniya Ksharakalpana was used, and Jalakumbi Churna in 6 gram BD with Naga Kesara Churna 6 gram BD. Oral drug significantly reduce the fibroid size up to P level 001. So these are some of the findings which have been put forth for your reference. So you can go through the contents on net and you can get benefited by the observations which already has been done in this field. So predominantly all the Ayurvedic studies were focusing on menorrhagia symptom, acyclical bleeding, pelvic pain, fertility issues, and what else? Dysmenorrhea. So, so in addition to this, a few studies have been carried out in Government Ayurveda College, Trivandrum. One of my senior has done one study. A few of my seniors have taken up the uterine fibroid as a clinical study. So it was also very interesting observations and ultrasonography we used to do ourselves, or through our the sonologist we used to get under his guidance also. So we observed a few packs which was very interesting in 2020s at that time. So it was at that time there was no much advancement in Ayurvedic field ultrasonography. So only modern practitioners used to have access to it. So these observations pave way for our improvement. And with this, I would like to conclude. There are many cases has been treated by uterine fibroid. I have mentioned a few of my experiences as the calcification and degeneration of the fibroid is very commonly observed in my observations. Patient will come back with the decreased size of the uterine fibroid from 4 centimeter to 3.5. Then after 3 months again, I need to convince, see the size of the uterine fibroid has reduced to 2.5 centimeter, then again 1 centimeter. Then some of the fibroids will not reduce in size, but calcium deposits or calcification on ultrasonography will be seen. So that we need not tell the patient that it has become calcified, and we need to understand that calcification is degeneration. So uterine fibroid will not further grow. If you get pain, you come back. If you don't get pain, don't come back. So that is the line of treatment which I advise my patients, and some conservative long-term treatment for the general Rasapachaka, Raktapachaka line of treatment can also be adopted. As majority are from Maharashtra, you can very easily get Rasapachaka, Raktapachaka dravyas. They are ready to hand and ready to use. And even Rasa Prayogas like Nityananda Rasa are very handy. So this practice is very useful as some metropolitan practices. Then Kada and Kashayapana like Varunadi Kvata, which contains Bhallataka, to be given cautiously, and all other Pathya Kalpana should be followed while taking Kashayapana. Asavarishtas, we can advise some of the Asavarishtas like Ashwagandharishta or Abhayarishta. Then we can use various other Asavarishtas also like Araghadarishta. So these things will enhance, and Lotrasava also to some extent will reduce the further growth of the uterine myoma. Whereas the patient, what is seeking fertility patient, OC pill use, I used to ask them to stop the OC pill use. So other than that, we used to continue all the other treatment modalities. Those who are willing for admission and treatment, we have given even Vamanottara Lekhana Basti, Uttara, we give Lekhana Uttara Basti, followed by Shamana or Brahmananga Basti. So this is the line of treatment which I have adopted in almost sitting, a week one sitting. Third sitting, I could give relief to the patient from irregular menstruation, menorrhagia or excessive bleeding, then menometrorrhagia, pain symptoms, and the dyspareunia, dysmenorrhea complaints. So within 3 sittings, we need to assure 20 to 30% result. Then the patient may come to us for follow-up. So this is my observations. Thank you, one and all. Thank you, Nima, for inviting me. And thank you, Dr. Vivek Jog and the Rakesh for coordinating, and also to Kamini Madam and all the office bearers for giving me an opportunity to present some of the data which I could collect in a time period. Okay.
Thank you so much, sir, for this wonderful and very informative sessions. Myself, Dr. Rakesh Nayak. Now I am going to take some question answer session. Sir, clinical cases in particular which you want to share with us?
Rakesh, you are not audible to me. Can you repeat the question?
Yes, sir. Clinical cases in particular which you want to share with us?
I didn't get your clinical cases.
Yes, you any particular experience?
That I have shared you just now. Clinical case studies I have told. One is I did a parvaginal examination. Patient went for vagal shock because of multiple uterine fibroids in the subserosal layer and myometrial fibroid of sufficiently bigger sizes. Abdominal examination was not done and directly PV examination was done. So that was complicated. That led to this complication. And the second, a few cases I told, generalized statement I told that in few cases, Varunadikwata, Nityananda Rasa, Abhyarishta, Lotrasava, Guggulu Diktaka Kashaya. So these were administered. So in them, the reduction in size was observed over a period of 3 months to 6 months. But the weight of the patient, the weight and BMI also got reduced by diet and exercise therapy along with Ayurvedic medication. But the problem was that patient developed kapakshaya lakshanas. So these problems has to be met. Patient developed multiple joint pain. So multiple joint pain. So it cannot be told as such because of Ayurvedic medication. But that lakshana, when I stopped the medicine, the lakshanas disappeared. So all these things then were my observation. So longer duration usage of Rasaushadis and Karshana Dravya should be kept in mind while treating uterine fibroids. Shorter duration with Panchakarma support, uterine installation of medicines can be done by an expert.
Thank you, sir. Sir, one question. What are the preventive measurements to avoid fibroid according to Ayurveda?
What are
the preventive measurements to avoid fibroids?
Preventive measures is lifestyle, Mamsa Pradoshajani Vikarani. So Mamsa Pradoshaja Vikara Nidana, it is told, already told. Then Rasa Pradoshaja Vikara causative factors have been told to avoid it. Nidana Parivarjana Chikitsa is the preventive measure.
Thank you. Okay.
So excessive use of Mamsala and Medura Ahara should be avoided. Then Anashana, Adhyashana, Vishamashana should be avoided. Then the excessive estrogenic, the harmonized materials, maybe Shakahara or Mansahara, harmonized materials should be avoided. So which contain estrogen-like material. So this is the primary line of treatment. Usage of vapors, then usage of untimely sleeping habits, over usage of gadgets. So these things all will lead to Mamsa Pradosha Vikara only.
Okay, thank you, sir. On behalf of Nima Obgy Society, Central Nima Obgy Society, Maharashtra body, I would like to express my gratitude to Nima Central, Dr. Vinayak Tambulkar sir, and Dr. Ashutosh Kulkarni sir, and Dr. U.S. Pandey sir for the remarkable support. I extend my gratitude to our Nima Obgy Central President, Dr. Kamini Dhiman madam, Secretary Dr. Priyanka Nakade madam, and Treasurer Dr. Vishnu Banve sir, and convey Dr. Rajesh Utane sir for supporting and guiding us and conduct today webinar. I would also like to thank and extend my gratitude to our eminent speaker, Dr. Ashokan sir, who took time from his busy schedule and delivered very knowledgeable and wonderful session. I would further like to extend my gratitude to our Nima Obgy Maharashtra President, Dr. Suhas Harlekar sir, Secretary Dr. Manoj Gaikwad sir, Treasurer Dr. Ajay Raj Bal sir for all their support to conduct today's webinar. I would also like to thank Dr. Girish Daga sir and Dr. Arpita Saha and Dr. Priyanka Chawle for the all help and technical support. Last but not the least, I would like to thank from the bottom of my heart to all the delegates from their participate and present. Without them, same webinar would not have been possible and succeed. Now, due to permission of all dignitaries, I am conclude today's webinar. Thank you all for attending and hope you have learned and gained great knowledge from today's speakers. Thank you.
I see one question in the question box, that is according to Ayurveda, who are prone to have fibroids, by Ajay Rajbal sir. So as such, there is no mentioning of prone to have fibroids. Those who are prone to get Mamsa Pradoshaja Vikara, those who are not of Mamsa Medo Sarata, they may get that. Those who are having Mamsa Medo Sarata and those who are Vyayama Sahishnuta, they may not get that. Those who are leading a sedentary life and those who are prone to get Mamsaja and Meso Pradosha Vikara, they are prone to get a fibroid uterus also, and it runs in family, as we know. Bija Dosha Janya Vikara, Garbhashya Bija Bhaga, Garbhashya Bija Bhaga Dushti. So that particular condition may get predisposition. Other than that, as such, mentioning of any literature, as per my knowledge, there is no available literature which says that the persons are more prone to get Mamsa Pradosha Vikara.
Thank you. Thank you very much, sir. It is very nice to see you, sir.
Thank you, sir. Thank you.
I am also thankful to Vishnu Bhavane sir, who invited me for the first time, who coordinated and who told, so you have to do some surgical intervention in Ayurveda in gynecology. So actually we were planning for something else. Later on, I landed up in Uterine Myoma. Okay. Thank you, sir. Vishnu sir, for Vishnu Bhavane sir.
Thank you, Ashokan sir. Thank you. See you, sir. Thank you.
If all can video have a group photo of the screen.